I call to order the October 16th Board of Health meeting at 5:30 p.m. on October 16th. As a reminder, the October regularly scheduled Board of Health meeting has been rescheduled for October 16th due to the Boulder County Board of County Commissioners declaration of the second Monday of October as a county holiday in observance of Indigenous Peoples Day. So item 1 on the agenda is public comment. As a note, the Board of Health provides the opportunity for the public to share their viewpoints and opinions on public health matters. It is not the practice of the Board of Health or the agency staff, many of whom are experts in their field, to review, vet for accuracy or grounding in scientific evidence, or provide responses to public comments at Board of Health meetings. Opinions expressed by the public should not be interpreted as accurate if staff or the board does not challenge that perspective.
Thank you, Landry. The first person we have is Marty Hopper. So Marty, I'm going to make you a presenter, and your 3 minutes will start whenever you unmute. Are you there, Marty? Okay, we'll wait for Marty. Oh, are you there, Marty?
Yeah, I am here, but I feel like I'm not seeing. Can you hear me?
Yes, we can hear you.
Can you see me now?
Yep, we can see you.
Oh, there. Okay, great. All right, thanks for being patient on that. Okay, so should I could start now?
Yes, you can start.
Okay, great, thank you. Okay, hi, well, Marty Hopper here from Boulder. A week ago Friday on October 6th, I sent an email to the Board of Health, the Boulder County Commissioners, Dr. Nolan and Dr. Belknap. My purpose was to express my continuing concerns about the dangers of the COVID vaccines. So my main points of evidence that I presented in that email, as well as just to go over those again tonight, are very similar to what I said back in August, but my concerns continue. And I did in that email send the links so that you can review this data for yourselves. So my evidence first about the dangers, first of all, there's been an alarming rise in all-cause mortality in the US compared to previous decades. And the death rate for the second half of 2021 for those in the 18 to 64 age group rose by 40%, which is quite alarming and mind-boggling. And this is the exact group of adults forced to get the COVID shots due to employer mandates. And these deaths were not due to COVID. Secondly, there's been an unprecedented rise of sudden deaths among young athletes globally. A Swiss study in 2006 covered a 38-year period and found an average of 28 young athlete deaths per year. Since June of 2021, which is since the vaccines were rolled out, there have been at least 29 sudden athlete deaths per month. In December of 2021, there were 90 such deaths, and you see this on the news if you watch sports at all. Thirdly, data from VAERS, as well as the CDC's V-Safe program, which has 10 million users, show alarming and historically high rates of death and injury among those who receive the COVID shots. And that has been released through a FOIA request. CDC has not released that data. Fourth, personal experience and our own local obituaries are further evidence. The latest very tragic loss is Tanya Briggs, the Lafayette City Council member who died suddenly in September at the age of 44. And just if you read the obituaries, look for the words died suddenly or died unexpectedly. Moving on to the trial data for the newest COVID vaccine, Moderna was tested on 50 people with a new formulation, no children or teens. Novavax used only monkeys, and the Pfizer trial used 10 mice with the new formulation that you are promoting on your website. So I ask you to please stop promotion of this or any of the COVID vaccines in any form. Thank you.
Thank you, Marty. Next, we have Carolyn Beninsky. Carolyn, once you unmute, your 3 minutes will start.
Okay, it looks like I'm on.
Yep, you're good.
Okie dokie. My name's Carolyn Beninsky and I live here in Boulder. I've been here many times before. I have more trouble getting here now because my work schedule has changed. First, I want to show you a book. It's called Neither Safe Nor, oops, sorry, I can't see whether you can see this. Neither Safe Nor Effective, second edition. And it's the evidence against the COVID vaccines in 700 plus medical studies. And much of the evidence in this book comes from government institutions, including the CDC and the FDC. The book was published in 2023, and I hope you will buy it and read it. It's very informative. Sometimes I wonder why I keep coming back to talk to you. You do not appear to have interest in what we in the public have to say. We presented you with the statement by CDC Director Rochelle Walensky on August 8, 2021, that COVID shots don't stop infection or transmission. And yet at one of your meetings earlier this year, one of your epidemiologists made the statement that BCPH should push the shots to stop the spread. It's clear that it doesn't stop the spread. So why is she saying that we need to push the shot to stop the spread? Very surprising. After the COVID shots were proven not to prevent transmission, we were told that the shots would reduce hospitalization. We brought you the results of a large Veterans Administration study earlier this year that the shots actually don't stop hospitalization. We bring you significant and credible evidence about the dangers and risks of the shot. It's clear that the risk-benefit analysis shows that there is no doubt that no human being should ever inject themselves with one of these shots again. But what we hear over and over again is that shots are safe and effective. And in reality, they are destroying people's immune system by causing the human cells to produce toxic spike proteins. And do we know if these proteins will ever turn
30
off?
seconds.
No, we don't. We really don't. But in the system called public health, there's no place for dialogue or discussing the data. The policies of pushing the shots never changes. New data and information don't seem to matter. The board meets in person, but combines us to screens. No eye contact, no seeing people who make decisions. Why do I come? I come for the vaccine injured and the dead and those who have not yet been adversely affected.
That's time.
To try to do what I can to stop the carnage. Thank you.
And then we have one other person sign up. Brian Scott, if you're online, could you raise your hand? Okay, I don't see Ryan online, so that concludes public comment.
Item 2 on the agenda is approval of the August 14th regular meeting minutes.
Hi, this is Morgan. I move to approve the August meeting minutes.
Okay. Any opposed? The meeting minutes are approved. Okay, we have some exciting personnel announcements.
Yes. In fact, we have 3 exciting personnel announcements. We are very pleased, first of all, to welcome Dr. Amber Johnson to our Board of Health. Amber replaces Greg Thomas, our previous board president, and she comes to us by way of Denver Health, where she is the Colorado Perinatal Care Quality Collaborative Quality Improvement Lead, which is a bit of a mouthful. So thank you. She's a certified nurse midwife and has a lot of focus on impacting healthcare education, public policy, quality improvement beyond direct patient care. So we are very pleased to have you with us, Amber. If you would want to say a few words, you're welcome to.
It was a great introduction. Thanks for having me. I'm happy to be here and serving on the board.
Welcome.
We're glad you're here. Thank you. Our second announcement is Dr. Indira Gujral, previously our Communicable Disease and Emergency Management Division Manager, has been promoted to Deputy Director. We are thrilled to have her in the role. Indira did so much during the pandemic to hold our agency together. I know that Morgan and Andrew will remember that I was just trying to figure out which way was up while Indira was really pulling energy from all across the agency and working with colleagues in all kinds of brilliant and effective ways. And I'm just really pleased that you'll be working as our deputy, and welcome.
Thank you. I'm excited to be here.
Yes. Okay, and third, is Bob online?
Yes, yes.
So Dr. Bob Belknap, who is our Chief Medical Officer, we contract with him, has been appointed the new Executive Director of the Public Health Institute at Denver Health. Are you there, Bob?
I am. Can you hear me?
Yeah, we just wanted to say congratulations to you and welcome in your new role. Thanks for not ditching us now that you're a big shot.
Thank you. Thanks for the introductions. I'm sorry I couldn't be there in person. I had a meeting that ran right up against this here at Denver Health, but I appreciate this team, and I very much appreciate the opportunity to continue serving as your Chief Medical Officer.
Thank you so much. Bob does a great job, and we're lucky to have him.
Okay, item 4, the 2022 audit results.
I'll go ahead and introduce today. I'm Desiree Kazarosian. I'm the Boulder County Public Health Finance Manager. CLA is our audit company. They also run the audit for the county, although we have different audits because we have an independent audit. So is Sam on the line?
Yes, he is.
So Sam, do you want to take it from there?
Thank you for that introduction, and good evening, everybody. I'm going to share my screen and just present on the 2022 audit results. Okay, so hopefully what you can see is page 3 out of 66 of the financial statement PDF. And what I want to do here is just start by thanking the Boulder County Public Health team. Special thanks to you, Desiree, Jessica, and Catherine, for all of the work that was done earlier this year to get through our report date. We were able to date the reports of the financial statements in August, early August, and that was much in advance of prior years. So as we continue to work towards completing the financial statement audit prior to the state's deadline of July 31st. We are working very closely with the district, with the county, sorry about that. And we'll continue to improve on this process and do this in a timely fashion. So if you may remember, the 2021 financial statements were presented. Those results were earlier in 2022. So we made significant strides towards that effort, and we'll continue to improve. So I just wanted to start by introducing myself. My name is Sam Hoig, and I'm principal at CLA, who did the 2022 financial statement audit. So our team was able to deliver an unmodified opinion over the 2022 and 2021 financial statements. Page 3 is the first page of our auditor's opinion, and it goes right into the opinions where it says, over the financial statements of the governmental activities and the major fund of Boulder County Public Health for those 2 years. It's a big effort to get through all of that financial statement information, as well as the financial statement preparation, including the MD&A, the management's discussion analysis, the basic financial statements, required supplementary information, and supplementary information. So the big thing to take away from this is that the financial statements, as you can review these going forward, that they can be utilized and be referenced to know that in all material respects, those financial statements are materially correct. So as I continue on to page 4 and 5, this is the bulk of our auditor's opinion. These paragraphs on page 5 go over the required supplementary information, which discuss the management's discussion and analysis, the schedule of proportionate share of net pension liability, pension contributions, and other post-employment benefits liability and those related schedules. So all of that information is required supplementary information under government auditing standards. And what this paragraph really references is that we don't express an opinion or provide any assurance over those schedules, but we do provide context as we go through the audit process to make sure that they are materially consistent with the financial statements. Other information that we do provide an opinion on is the supplementary information, and this would include the schedules of revenues and expenditures by function towards the back of the financial statements. So table of contents references each of these paragraphs, but I just wanted to lay that out for you in terms of what makes up the basic financial statements and what else is included in this document. So if we go to page 6, the management's discussion and analysis would provide really over the next several pages, financial highlights for the years 2022, 2021, and 2020. So it's a good summary of those years and comparisons for both future reference and historical look back. I want to go to page 12 to go with the first page of the basic financial statements. This is the government-wide statement of net position for Boulder County Public Health. This would encompass anything that's related to both current as well as long-term assets and liabilities. The balance sheet is a conversion that occurs in governmental accounting where we focus only on the current financial resources. So it excludes things like capital assets, pension-related items, as well as any long-term debt if that were to arise. So the big thing I wanted to note, because this focuses on long-term assets as well as liabilities, is that the statement of net position has or reflects a total net position that's in a deficit 3.7 million as of December 31st, 2022. I'm going to flip over really quick to the balance sheet, which this is over the governmental fund. There's one primary fund with Boulder County Public Health, and that reflects a more positive total fund balance of 5.6 million. As we go to the next page, if you wanted a breakout of what makes up the difference primarily between those two statements, modified versus a full accrual, it really encompasses just the related to pension and other post-employment benefits. So those two liabilities are not included on your current financial statement resources focus that the balance sheet reflects. And in that case, if you wanted to look at something from a more current, how is the entity doing year over year, those two statements, the balance sheet and the income statement on pages 15 and 17 would provide a little bit of an easier context that would exclude some of those larger fluctuations in pension and other post-employment benefits. So any questions there before I continue? Hearing none, real quick, I wanted to go over the unavailable revenue. So this is one finding that I'm going to go into more detail, but I want to provide some context over the concept of unavailable revenue. So as we look at the balance sheet, we have this item here that's deferred inflow of resources, unavailable revenues. 478,000 as of December 31st, 2022, and 772 as of 2021. So this item is a governmental accounting concept that focuses on modified accrual, and it's only based on the period of availability concept with government revenues. And it mainly deals with, we're trying to match up expenditures that are current with revenues and the period of availability. So what does that mean? For Boulder County Public Health, they've deemed period of availability as 60 days of receipt subsequent to year end is what's considered available. So if we went to the statement of net position back on page 12, there would not be a liability for that or a deferred inflow related to unavailable revenue. So I just wanted to point that out. That's another difference, full accrual versus modified accrual. And that's pointed out on the reconciliation between the balance sheet and the statement of net position. So that's where this line item shows up here. So I'll go into this into detail as I explain the finding that occurred during this year and a couple of audit adjustments that occurred, but wanted to really point that out just from how that is conceptualized in those two statements. As we go into the notes to the financial statements. This is also captured within the basic financial statements that we provide our auditor's opinion over. There were no real significant changes to these footnotes. I will say that GASB 87 over leases was adopted and implemented in fiscal year 2022, and that did not have an impact to the financial statements. So I can go into more detail about that, but it's basically one standard that was several years in the making, and it basically made one big statement for all types of leases on the lessor side, the lessee side. And if anything was material from a lessee or lessor perspective, that would be really captured on the balance sheet or the statement of net position. So that's just where the big gross up would have occurred if there was anything significant. But the takeaway for Boulder County Public Health was that there was no significant leasing activities that required adjustment to these financial statements. I'm going to go to the end here, page 63. So really, if you wanted to go through the rest of the financial statements, the notes would go all the way through to page 46. And then this is where you start getting into some of the schedules for required supplementary information and other schedules. So the real result that I wanted to just go into and provide some more context for the board was over our report over internal control over financial reporting. So this states that we are engaged to provide an opinion over the overall financial statements, but we don't provide an opinion over the effectiveness of the entity's internal controls. But part of our process is to review things and make sure that they are materially stated. So if we come across anything that warrants a big correction or something was missed, it could rise to the level of a finding. And so that's what this report would go into. What this page states is that we had one certain deficiency that was a significant deficiency. It was item number 2022-001. And what a significant deficiency is one level less than a material weakness, but it has to be one of those two classifications of a finding that warrants communication in this report required under government auditing standards. So I can go into more detail about material weakness and significant deficiency, but I want to go into the finding on the next couple of pages. So this deals with what I was talking about previously with unavailable revenue. And a little bit more about unavailable revenue is that it's primarily a year-end entry. So it's something that deals with accounts receivable cut off in that 60-day period subsequent to year end. So it really isn't something that we would expect to be adjusted throughout the year or be a focal point. It's something that just has to be done with the financial statement preparation at year end. Now with that, we had a couple of adjustments and corrected audit misstatements, we classify them as, that had to be fixed and generated this finding. At the end of the day, there was two reasons for this being a finding. In this paragraph, we note that revenue was recorded and accounts receivable was recorded, and some of those balances were not received within that 60-day period after year end. The other piece was that we identified adjustments to unavailable revenue at year end, but it did not have an offsetting accounts receivable and revenue entry already created. So what does that mean? If we just look at the effect, at the end of the day, with all of our aggregate adjustments, we increased accounts receivable by 187,000. We increased unavailable revenue by 291,000, and we decreased revenue by 103,000. And if you think back, that's only on the income statement with the general fund. So government-wide, this unavailable revenue entry did not hit that, but it is a general fund impact, and that's why we had to reflect it as a significant deficiency, just given the number of adjustments and the dollar amount.
Sam, you have
So-
a question?
Morgan.
Yeah, Morgan.
Yeah, thanks. So just before you get off of that, because it has to do with internal, it seems like control, is that something that we then can and have updated within our internal controls to ensure we don't repeat the same things in future audits? Is that?
Yeah, I can speak to that, Morgan. We've brought in the county to help us and to shadow us in this process this year. There you go. Hi. So we're working, we're one of the only departments at the county that doesn't go through this review with the Office of Financial Management. So we've asked them to come in and walk through their processes with us. So we're going to be mirroring the county processes going forward.
Great. Thank you. I think I saw that in the notes, but that mirroring would then eliminate that going forward.
It would. The county actually had the same finding in 2020, so they walked me through that as well.
Great. Thank you.
Good question. Any other questions over the financial statements or any areas that I skimmed over that you would like me to go into more detail over?
Thank you.
I do want to go into one other document that we issued, and this is specific to the governance communication. So this is 18 pages this year, but the first 4 pages are what summarize really the significant findings, communications, anything that we are required to communicate with governance over the course of the audit for 2022. So the first paragraph goes into, again, our audit over the financial statements for 2022, which includes the governmental activities and the general fund. Accounting policies, if there was any significant change, this would be reflected in note 1, that summary of significant accounting policies in the financial statements. We just wanted to point out here that GASB 87 leases was adopted, but did not require a change to the financial statements. This is something that going forward, just to keep in mind, it is something that we have to look into every single year for any significant leasing transactions. And as new GASB standards come through, this is where any of those would be pointed out for adoption in that year. I'm going to skip down to page 2 here. So when we look at things from difficulties encountered in performing the audit, we didn't note anything to disclose there. I'm going to skip real quick down here. There were no disagreements with management, and we have the management representations in a letter attached to this document as well. I'm going to explain a little bit the uncorrected and corrected misstatements. So uncorrected misstatements are simply those that we identify that are incorrect, but they are immaterial to that opinion unit, whether it be the general fund or governmental activities, to the financial statements as a whole. So that attachment is attached to this letter as well, and it simply notes and outlines those things that we identified that were passed on or not corrected in the financial statements. Corrected misstatements would be those audit adjustments that we identify and management agrees with that actually were updated and adjusted in the trial balance that got reflected in the 2022 financial statements. So both of those exhibits for uncorrected and corrected misstatements are attached to this letter as well. I wanted to point out that only the corrected misstatements over unavailable revenue warranted a significant finding. So there were other things that were identified that were passed on or even adjusted in the financial statements, but did not warrant any other significant findings. So this occurs frequently with entities of any size that we deal with, and I just wanted to explain some of those. And I can go into those in detail if you'd like me to, if the board has any questions over this letter.
I'm good, thank you. Thank you. We're good.
Very good. That was the extent of the reports that I had to present on. So just wanted to say thank you again for the time this evening, and thank you for Desiree for all the assistance back during the engagement. We look forward to working with you next time.
Thank you, Pam. Appreciate your time.
Item 5, we're going on to the OWTS variance hearing.
Okay, thank you. So tonight we have our first variance request from our OWTS team since I've been here at least. And I will turn it directly over to the team to walk us through this process.
Hi, yes. Good evening, everyone. I'm Celeste Gleason, she, her, and I'm the water quality team lead. I'm going to have Stephanie introduce herself in a second. She'll be presenting on this specific variance, but first I just wanted to check in and mention that we have not brought a variance to the Board of Health since I think 2018. So it's been a while, and I think most of the board has changed since then, maybe with the exception of Morgan. But so in the Board of Health packet that you reviewed, I did include a link to the variance section in our regulation, and I included a section on the board's roles and responsibilities for granting variances. And I just wanted to quickly check in to see if any board members had general questions about the variances before we dive in.
Your background material is very helpful. Thank you.
Yeah.
Yeah, agreed.
Okay.
Really helpful to have that. Thank you for sending it.
Okay. All right, Steph, go ahead and introduce yourself and take it away. And I'll be here too in the background.
Hi, my name is Stephanie Fontanini. I am an environmental health specialist with the Water Quality Program, primarily working with septic. Pronouns are she, her. And then I would also like to mention that the engineer for the septic design is present as well. It's Kate Carney, who designed the system. And if you have any sort of technical questions regarding treatment level, how the system works, Kate mentioned that she would be happy to answer those. So a summary for this particular variance is basically that it's in Eldora. It's an area of very high density, and the existing structure on the property is a 2-bedroom cabin. Typically, all OWTS regulations would require the soil treatment area to be located 100 feet from wells. This request specifically is to locate at 75 feet from the on-site well. That would still be a minimum of 100 feet from any neighboring wells. Due to the small size of the property, less than a 1/4 acre, there is no possible way for the 100-foot setback to the on-site well to be met with having a soil treatment area. And then various requests for existing wells may be granted by the local Board of Health. For new wells, they're typically issued by the Division of Water Resources. Next slide, please. So this particular proposal is for 603 Klondike in Eldora. You'll see the outline in red. The well is going to be on the south side of the house there, near the road on the bottom. The proposed leach field would be near the northern side of the property, just south of Klondike Avenue there. In designing this particular system, it accounted for all setback features. They looked at a survey, did a site visit, both Boulder County Public Health, myself, and the design engineer. And then we also looked at existing records for neighboring systems and neighboring wells. The proposed new on-site wastewater treatment system includes the use of a higher level treatment septic tank. It's an Orenco Advantex AX20, which is sufficient for design flows up to 500 gallons per day. This particular one would be for 300 gallons per day, so well over the minimum there. And then the treatment level is a TL3N, which means the N meaning that there's a nitrogen reduction in that advanced treatment. And then the horizontal setback between a soil treatment area and a well may be reduced to 75 feet with TL3N effluent and a variance. So typically when the diagonal distance from the soil treatment area to the base of the well grout is 100 feet, as long as that horizontal separation is at least 75, a variance would be allowed. Or possibly when no closer than applies, which would be the case here with a local Board of Health approval. Next slide, please. So the existing vault is on site. Boulder County Public Health records approved it in 1979. It was measured to be 71 feet from the on-site well by the engineer. Our records show it is 70 feet from the on-site well. The proposed soil treatment area, if you look at that gray box on the northern side of the house, will be located 75 feet from the on-site well. And that diagonal separation between the soil treatment area and the base of the well grout is 79 feet. So it is likely possibly even a foot or two more than that, given that the soil treatment area is upslope of the well and that is calculated using the Pythagorean theorem. For repairs, on-site wastewater treatment system repairs, components that don't meet the required separation distances may be located no closer than the existing on-site wastewater treatment system. And by definition in the regulation, a vault is an on-site wastewater treatment system. So it would fall under that, allowing no closer than to be used with a variance. Next slide, please. So there are two alternatives. One would be to grout the existing on-site well. The owners looked into this. They talked to a well driller. They determined grouting the existing well is not possible. Even if they did this, the variance for the horizontal separation reduction to 75 feet would still be required. So they'd still be going through the variance process. It would just be, I think the only option there would be to drill an entirely new well. The other option would be the continued use of the vault. And some items to consider there are that pumping access is very limited, sometimes impossible in winter conditions. So currently the owners limit their use of the property in the winter so that they're not filling that vault and getting in a situation where it's overflowing and they can't get anyone to pump it. So that is currently definitely limiting their use of the property and posing a public health risk if it does overflow and there's no way to get it cleaned up with winter conditions. Next slide, please. So the considerations here, if you look at the design, all of the neighboring wells will meet the 100-foot setback to the soil treatment area. This would just be for the on-site well that would be reduced to 75 feet. To reduce horizontal setbacks using advanced treatment, the regulations require an operation and maintenance use permit. We call those O&M use permits with Boulder County Public Health. So basically the owner would have to show they have a contract with a service provider who every year is going to inspect that Advantex system, make sure it's functioning properly. And then the owner is required to submit that inspection report along with the contract they have with the service provider and a use permit renewal fee. So that would allow us to keep an eye on the system, basically, make sure it's working properly, and just kind of have that relationship with them as well. The proposed advanced treatment system will be an improvement from the existing vault. It may actually reduce the public health risk. And then the approval of the variance is supported by the CDPHE on-site wastewater treatment system coordinator, Chuck Cousineau. So our recommendation in this scenario would be to approve the variance request.
Thank you. I just had a quick question. Is there any ongoing testing of the water? Or just
Go ahead, Celeste.
Do you mean the well water, the drinking well water?
yes.
So we actually can't require that in our regulation. It is a private well. So if the property owners want to do that, they can choose to do that on their own for E. coli and other coliform, but it's not actually something that we can require.
Thank you for all that education. Do you have any questions, Morgan?
I don't know. I again, like, I just compliments to staff on being so thorough and both, you know, the work that I know you all did to review this, but also then in providing materials to the board, because I think I don't and feel confident in your professional recommendation. So if nobody else has questions, then I would move to a motion, but.
Yeah, let me move.
Can I ask a question?
Yeah, of course.
Thank you. Joe Malinowski, Environmental Health Division Manager. I just had a question. I support the homeowner doing this. I have concern maybe for the new, if they would sell it in the near future. So, but I understand the variance would be part of the record in the with the planning and permitting at the county. So somebody doing their due diligence would be able to see that when they purchased a property if they look at it ahead of time.
Yes. Yep, they would see that because it's going to be an entirely new system. It would be exempt from our property transfer requirements for 5 years. However, if it gets sold after 5 years, we do require that it would get a property transfer certificate. And again, during that, we would be making sure that their use permit, their O&M use permit is up to date, that they've got a new contract in place and all of that. or if it's sold.
And then Kate, we see your hand up.
Yes, thank you so much. This is Kate Haywood. I am an assistant county attorney with the Boulder County Attorney's Office. I just wanted to make a couple of points for the board since this is new for most of us. With respect to the variance process, the board does have authority under the regulations to issue site-specific conditions as a condition for granting a variance. So, for example, if the board did want to consider, testing requirements or similar, we could definitely look into that. That seems like it could be an option if that was the preference of the board in the agency. And then also to Joe's point, the conditions of the variance are required to be recorded on the deed of the property. So the conditions of the variance should be known to any future buyers.
Yeah, I mean, this certainly isn't my area of expertise, and this is great to learn about, but it seems like the point is to keep the water supply clean. So it would make sense to me to have ongoing testing of the water in addition to making sure the system is functioning. But I don't know what our role is there. Sounds like we don't have jurisdiction over that.
Well, and I would be curious what staff says, because Landry, I mean, what I'm remembering from sort of our more in-depth conversation about on-site water treatment from last month or the month before was that we don't test really anybody's on private property. And so my concern would be applying a particular rule. And I understand we're doing a variance here, but like, I think I would have to hear some pretty heavy concern from staff that there was an increased risk to just to the safety of the well water to attach that kind of.
I'll see if Kate Carney wants to speak to anything, but I will say that there are other I guess like other properties that are using the same type of unit that we don't have those requirements for. So I do think it would be, again, it is totally up to the board, but I do think it would be hard in the sense that we don't have those requirements for other properties that are using the same unit. But Kate, go ahead.
Yeah, so my concern would be that there are neighboring properties that don't have any kind of advanced treatment at all on their systems. And so if this well were to show contamination, it would likely be from those neighboring properties that have been legacy systems that aren't providing treatment. So then at that point, how would you go about improving water quality? Would you force the neighbors to upgrade their systems to higher quality? And it could really complicate things.
I would not suggest putting in a special case here. It's just, I just find it interesting that we don't test the downstream consequences of these systems. This sounds like a huge improvement. I'm just sort of academically saying what we care about is the water quality, and we're not really doing anything about that. In any case, I wouldn't want to make this a special case. I don't think that's fair to the homeowners.
And Jefferson County has the Indian Hills area that has nitrate contamination noted in their watershed. And these are the type of systems they are recommending and requiring those properties to upgrade to improve the water quality.
And the other thing is, I mean, there is my understanding, right, is someone who's maybe purchasing, if they were purchasing this property or purchasing another property, they can certainly opt to test the well water themselves for sort of their known safety before they're using the well water, right? I mean,
Yes,
but that would not,
correct.
the record of that would not be available to us, or the results of that would not be available to us.
Correct. Yep. Yeah, when people are buying properties, whether there's a higher level treatment involved or not, we definitely always recommend that they take the due diligence to test their well water for contaminants. But because it is private, we don't require that for property sales. And they can choose to make that not public record, as you mentioned, Morgan.
Kate Carney, could you please introduce yourself for the record, just so I have it?
Yes, I'm sorry. I'm Kate Kearney, PE with Church On Site Wastewater Consultants, the design engineer for the property.
Another question, go ahead.
Hey, Joe Malinowski again. Does it make sense at all to do just a preliminary water test, even if we're not doing ongoing, just to see, you know, before the system is installed, what the water looks like as far as potability?
Kate might know if they've done that already. I don't know that. And you could certainly, like if I was the homeowner, I would do that because I would want to know, but finding the reason of if it is already contaminated, finding the reason of that could be very hard, like Kate mentioned.
I think the other thing I would be concerned about is like if the owner of the property tests the water and they find out that there's a problem, then they can decide, right, how they want to deal with their well water. But then if we make them do it, then the results of that then are part of the public record, right?
Correct.
Yeah. And again, like I'm just thinking about what's fair to this property versus others that we have not done that to.
No, I was just gonna say, I think Morgan actually already did
Made
the
a
motion.
motion.
to
Yeah, if
approve,
there are no further questions, you made a motion, Morgan?
Oh, nope, I don't think I have. I would, I guess I would move to approve the variance request.
Yeah, I think this is a net improvement with the constraints of the property, so I would second.
I agree. So we approved to, the variance for 603 Klondike Ave is approved.
And again, appreciate all the work that staff did and just the information is really helpful to inform our decision.
Thank you so much for your time. And then after this, just so you know, we do get this recorded like Kate Haywood mentioned, and then follow up with a letter to the property owner as well. So thank you for your time tonight.
Thank you.
And just to jump in real quick, to clarify, under the regulations, it is the property owner's responsibility to ensure that this gets recorded, but Celeste, we can link up on that.
Thanks.
Yep.
All right, item 6, public health improvement plan discussion.
Kelly, are you introducing this or am I, or is Denise? We haven't.
You know, that's a great question. I can introduce if you want. Go for it. So, yeah, and you can add if I miss something. So, thanks everyone for joining. My name is Kelly Hinch, she, her pronouns. I am the Strategic Initiative Director. And tonight we're going to be talking about our Public Health Improvement Plan, which y'all have been involved with a little bit. And it's going to be an update to that plan because we've wrapped up sort of the first draft of that plan. The first draft, I think, is several drafts of this space, but it's a presentable draft of that space. And it's, again, our 5-year public health improvement plan, which is statutory obligated by the state. And the focus of that plan is mental and behavioral health. And with us today, we have 2 leaders from our health, from our HBE team. And my God, it's like Monday. What is this? I don't even know. The health planning and evaluation team. I used to manage that, by the way, just so you know. And they're both super stellar, future public health Hall of Famers. And I am going to let them take this presentation forward. So Elise Wallon, and who's the HBE manager, and Rachel Mental, who is our health planner, and they're going to lead us in this conversation. So go for it.
All right, I will take it away. Hello, everyone. I'm Rachel Mental, and as Kelly mentioned, I am a health planner within the Strategic Initiatives branch. I use she, her pronouns. And with us, as Kelly mentioned again, is Elise Wallon. She's our health planning and evaluation program manager. And tonight we are going to share with you our I'm going to call it a finalized CHA and FIP, Community Health Assessment and Public Health Improvement Plan. And I say finalized because I'm hoping that what we're presenting to you all tonight is something that you all are excited to learn more about and approve next month. So again, we're just going to breeze through a couple of slides for our presentation and then hopefully leave some time for discussion for you all. You did receive in your Board of Health packet the documents of our 2023 Community Health Assessment and our 2023 through 2028 Public Health Improvement Plan, as well as a lengthy presentation that hopefully provided some additional context for you all on those documents, the CHA and the FIP. Again, we're going to talk about a couple of things today, and then we will come back next month in November to formally request approval to allow you all some time to digest the information and ask any further questions before approving. I think we can go ahead, to the next slide. Actually, we'll go to that one. Thank you. Okay, so this was a slide, it was included in your Board of Health packet. So I won't spend too much time on it, but just really wanted to kind of highlight the process that we followed with our contractor, Omni Institute, who facilitated this process for us. So this is outlining our community health assessment process that kind of led to the development of our public health improvement plan. So this process included reviewing data, highlighted our strengths and opportunities to improve mental and behavioral health within Boulder County. And it also allowed us to look at some disparities in the data and identify some focus populations that we can work with when we're implementing our strategies. A big part of the community health assessment and public health improvement plan process is community engagement. And we were actually able to utilize a lot of existing qualitative data and community engagement that was collected from our partners. And we did that so we could avoid overburdening our community, who had already been asked a lot for their opinion and for their feedback. And it also helped us to avoid duplicating efforts from that information that was already collected. The community health assessment process also included a capacity assessment. So that looked at BCPH's strengths to kind of improve mental and behavioral health to implement our strategies. And it also helped us look at where we might be able to take a supporting role in some of these initiatives based on maybe some of our partners that may have additional strengths. And if you want to go to the next slide, I'll talk a little bit more about how we used the CHA, our community health assessment, to kind of transition into our public health improvement plan. So a few different examples, kind of key points to really look at how we connected the CHA with the FIP. The CHA really helped us as the CHA FIP work group make those data-driven decisions. So it helped us, like I kind of mentioned before, identify some of those priority populations that we really want to focus on when we are implementing our work. So an example is that according to the data that we reviewed in our CHA, a larger percentage of our LGBTQ youth reported experiencing mental health issues compared to heterosexual youth. So that's a population that we may want to focus our efforts on a little bit more in our public health improvement plan. The CHA also helped our work group in looking at areas, as I mentioned, where we can be leaders, but where we can also provide support. So again, looking at the data, there were some data points around older adults and mental and behavioral health. And we have some agencies in the county that are already doing a lot of work with older adults, such as the Area Agency on Aging, or AAA. So that's an area where we can provide support and collaborate with them, but other agencies might be better situated to be leaders in that, in implementing those strategies. And then finally, the CHA also helped us really focus our strategies on where public health scope of work lies, which is in primary prevention, early intervention, and harm reduction. If you want to go to the next slide, I'll talk a little bit more about those 3 areas. So mental and behavioral health is a really big topic, right? So again, the community health assessment helped us kind of stay focused on where public health does our work. And that's in primary prevention, early intervention, harm reduction, especially when we're looking at the countywide initiative, the behavioral health roadmap, creating that coordinated effort to improve mental and behavioral health. We wanted to focus on where is public health fit. So in terms of mental and behavioral health and primary prevention, we are really focusing on decreasing those risk factors and increasing those protective factors for mental and behavioral health. Early intervention, we focus a lot on the screenings and assessments, so that early detection of mental health challenges and some of those really early interventions. And then we also focus on the harm reduction and our leaders in this space in a lot of ways as well, reducing those negative consequences associated with drug use. Next slide, please. All right, so as you saw in our FIP, and I think we've presented on this before, through the community health assessment and identifying those strategies to focus on, we landed on ultimately 4 goal areas: community understanding, policy, social connectedness, and sustainability and funding. Originally, I think we had presented to you 5 goal areas, but we were able to combine and condense a little bit to create these 4 goal areas. Each goal has objectives underneath. Some of the objectives are outlined for year 1, so things that we want to complete in the next year. And then there are also objectives that we want that are subsequent to year 1, and we will complete through the remainder of the plan. If you want to go to the next slide, please. I'm going to dive a little bit deeper into the objectives. And this is really kind of showing a high-level summary of the objectives. They are more specific than this. But we really wanted to highlight that the objectives that we developed in our FIP are building on the existing BCPH programs that we are already implementing, but having them in our FIP and kind of elevating them with additional resources can help us create a more focused path and greater impact by kind of having a strategic and coordinated way of going about the work. So an example under the community understanding goal. Strategically coordinating and conducting training and technical assistance. So we, as a public health agency, especially in mental and behavioral health programs, we do a lot of training and we provide a lot of technical assistance, and we have some we're really strong in that area. However, elevating it in our FIP can help us be a little bit more strategic in those efforts to create that greater impact and working with partners and the community to provide those trainings and technical assistance. Similar with policy, BCPH is very involved in policy development and with MB8, mental and behavioral health. But by creating a goal and objectives around it, we can really be intentional about developing a specific policy agenda that's going to help us advocate for policies at the organizational, local, and state levels. So these are just a few examples we wanted to kind of highlight, again, that we're building off of the current programming that we're doing to kind of elevate that impact. If you want to go one more slide connected to this, this is a list of the programs that have a direct impact on mental and behavioral health at BCPH. So each of our divisions has at least one program working directly on mental and behavioral health. We have a lot of programs that still impact mental and behavioral health, but may not be as explicitly linked. So emergency preparedness, as an example, a lot of the work that they do in preparing for and responding to emergencies obviously has an impact on our community's mental health, but it's not as explicitly linked as some of these other programs. Want to go to the next slide, please. Just a couple more slides and then we'll open it up kind of to questions that you all may have. So where are we going next? So upon approval of the RCHA and our FIP, we are planning a community launch in early 2024. So this is going to be in conjunction with our strategic plan. If you may remember, our strategic plan, one of our priorities is mental and behavioral health, and we are adopting our FIP goals and objectives into our strategic plan. So we will do kind of a combined launch of our strategic plan and FIP in early 2024. We'll be sharing these documents on BCPH's website, working on translating those documents into Spanish and making sure that they are ADA accessible. Again, in conjunction with the strategic plan, we'll be implementing our FIP with our other strategic priorities, which would include building out some detailed plans of what that implementation will look like, following a monitoring, evaluation, and learning plan, which will help us adapt to any needs that might come up and continue to align with partners. As I mentioned earlier, the behavioral health roadmap, which is being developed, and they're going to be planning for their implementation soon. We may need to make some adjustments based on what other partners are doing, and we can do that based on our learning plan. Next slide, please. All right, so this is where you all come in. We will be coming back in November to request formal approval of the Community Health Assessment and Public Health Improvement Plan. We are requesting that if you, as you're reviewing, if you have any questions that we can answer, or if you have any specific changes that you as the board would like to see, if you could get those to us, the HPE team, by November 3rd, that would really be beneficial to us, so we can make sure that we incorporate those changes and have everything ready to go for you before the November meeting. And then once approved, we will submit it to CDPHE, as again, it is mandated by the state, as Kelly mentioned. I think that was it on that slide. If you want to go one more slide. Really just wanted to highlight all of our colleagues that helped with this process. All the staff listed on here. This was in addition to their regular workload for the majority of these staff, and they provided some invaluable insight and work, and they reviewed data, and they came to meetings and really helped develop this. We couldn't do this work without this work group, so I really wanted to thank all of the members of this TRAFIP work group for their continued support over this last year, I think. Can't remember. I was not here when you guys all officially started this process, but about a year. So thank you to the work group members. And then we'll go to our final slide, which is where we'll leave it at questions for you all. We put a couple of guiding questions on here if that's helpful. If you guys had anything specific that you wanted to ask about, there's several of us here that can answer these questions. But really just kind of starting with, do you guys have any initial questions or thoughts or concerns about our public health improvement plan? And then is there any information you would need, you feel that you might need in order to approve this at the November meeting?
Thank you for the level of detail. This is a great presentation. I guess just as an employee at Clinica too, I'd be happy to help coordinate any more with that we can with Clinica for some of these initiatives. So I know there's a lot of overlap.
Thanks, Elise and Rachel. I'm very new to this FIP and CHA. Did I get that right? So this is a really helpful overview. I do have a few questions because I'm pretty new to this material. Hopefully you can humor me. One, you mentioned that your 2018 to 2022 plan was also mental health, which, as we know, other focuses were more important starting in 2020. And so that plan probably got a bit derailed. So I'm wondering, is any of this a continuation of the work that we started in that 2018, 2019 plan?
Yeah, I'm happy to jump in first. And as Rachel said, there's a whole slew of us who can tag team here, and also acknowledging, since you are new, Amber, Rachel Mintle joined our health planning and evaluation team in November of 2022. I joined the team in August of 2022. So we were a fairly new team. And so we definitely have some colleagues that are in the room there with you, have a lot more historical perspective. But at least kind of very high level answer to your question is that yes, generally, the focus of the previous FIP, to my understanding, was specifically mental health, and there was a variety of reasons that was chosen at the time. And as you alluded to, over the course of 2020 to 2022, a lot shifted within our county and in terms of focus and priorities. And so the selection of mental and behavioral health for this FIP was definitely a nod to the fact that there has been a lot of planning and time and work invested in this space, but that a lot of our efforts were somewhat derailed or put on the back burner for the time being. Additionally, in that time frame, the county overall initiated some data collection through kind of the ARPA process for gathering information from the general community on needs and priorities, and mental and behavioral health was certainly one of the pieces that rose to the surface, which kind of, I think, solidified that decision for our agency to select it as a priority. And then last but not least, certainly in looking at the data, clear indications that over the course of the pandemic, many mental and behavioral health indicators did not show improvement. In fact, saw dramatic declines, or maybe not necessarily declines, but persistence in maybe trends that we would want to address. Kelly, Lexi, and Indira, all of our colleagues who have been here much longer, I don't know if there's anything else you wanted to add in terms of kind of perspective on why we also selected MBH for this round for the FIP.
Yeah, I'll pitch in, and I think Indira is been here longer than me with this space. And so I feel that, so before, you're right, COVID like totally derailed everything. We all switched jobs, right? And the reality is during COVID, we also switched to an internal mental health sort of focus as well, which is super helpful for staff, right? But like other LPHAs in the state, whose public health plans also got derailed from COVID, we did see, as just as Elise was saying, sort of a nosedive in that same space. And we also saw, on the behavioral health side, also saw an uptick in that and space, problems in that space. And we're well positioned, right? I think when we looked at the mental health space in the plan before, it was a little bit siloed, right? And so the approach we're looking at here is different. And I think that's important to recognize, that we're recognizing that we do a lot of this work already. And so where we're really looking at now is wow, how do we bring that stuff together sort of? And, like Rachel was saying, that strategic thinking space of it, right? How do we maximize? And some of that is saying, wow, we could really step up in this space. And sometimes it's maybe we can step back from this space too, right? And so, yeah, I think we made a fundamental shift in continuing where we left off. Not that that didn't build foundation, it did the last plan, but I think now we're launching off that, what we've built. So that's my opinion. I don't know if you or Lexi.
I think if we go back to that one slide that has the 4 focused areas, the 4 overarching kind of goals. This one? Right there. I would say that the difference between last time and this time is probably in the community understanding. So as the opioid crisis in particular has gotten worse, we've had to do more training in the community, particularly with different community members, understanding harm reduction, understanding naloxone. So that has really increased a lot. And then we've always had strong policy, I think, in the MBH space before. And then, this concept of social connectedness, and I think we can go really deep. And I think this is universal across the whole country is looking at this. So there's an opportunity, I think, for probably more community engagement and for us to start moving into that space slowly. And then the last piece is we just have not had sustainable funding. So mental and behavioral health is run, most of our funding comes from CDPHE, and mental and behavioral health funding for local communities really runs out of the Behavioral Health Administration now. And so it's never been something, even though everyone across the state all these LPHAs have identified mental and behavioral health as their top priority. We just don't have that secure funding coming to us like we do other forms of streams of funding coming from CDPHE. So that is going to be, it's going to be interesting, I think, over the next 5 years to figure out if public health is tasked with this monumental task, how do we make sure to fund it? So I think that'll be interesting to watch.
Yeah, that's a great point. I think the dual focus is absolutely warranted. I think it was really smart of you all to include them both.
Yes.
I'm all here for it. You also mentioned that with your goal of having a really equity focus, you really need flexible funding too. So not just sustainable, but flexible. I guess maybe some examples of what that means.
Well, I mean, even just in this past year, the challenges we've had in the Works program have been, it's not just your traditional opioid, it used to be black tar heroin was the major drug of choice, but the drug landscape is changing. So then we had xylazine, now we're seeing these other weird, strange analogs coming out. And because the drug landscape is changing, if we just have funding that's specific to specific things, we can't fund buying xylazine test strips, right? So then you have to be able to be flexible in what you're dealing with. So I also think that, the pandemic, a lot of young people
really are struggling, right? So do we have the youth prevention and primary prevention funding? I don't necessarily see us doing that. So if we had this flexible funding, it would allow us to really assess our community and be able to say, these are where we need to put our resources. These are our priority populations. These are the highest risk folks right now, and we have limited resources, so where do we put our money?
Yeah, not only, I think one more thing really quick to add to that is when we talked about partnerships, I mean, that's where that comes into play a lot too, right? Because if we're looking like, for example, at Boulder County or, you know, Sister Carmen or whatever, you know, those type of spaces, how do we best leverage those spaces, right? When we talk about community engagement, which is part of our strategic plan priorities, how do we do that better because of the limited funding, right? So between us, it's like, you know, the honeypot's only so full, right? So, you know, you got to figure out how you can best spread that around a little bit. So I think that's an important aspect too.
And have the biggest impact.
Yeah.
And does that funding need then like also kind of flow over into your policy world where you're also hoping to advocate for policy that supports flexible funding for this? I guess I was reading through the policy stuff, which I think absolutely, again, I think this is the space that we need to be in to have a larger impact. But again, are there kind of some examples of policies either that we've already started to go for in this space or like examples of what you all are thinking of when you say like, let's advocate in the policy world for mental and behavioral health? Dave is on.
Pardon me?
Dave is on if he wanted to.
Oh, yes.
But I don't think those.
Dr. LaRocca is on, but so he can speak that. Before he jumps in though, I mean, even some of the things we've done last year, like when there was a lot of LGBTQ, for example, legislation that we supported or we provided testimony for and that type of thing like that. That's also plays, right? So it's that downstream space also, right? It's not so much bringing money necessarily, but it's that understanding of that. I don't know, Dave, can I put you on the spot?
Yeah, sure. Hi everyone. Dave LaRocca, he, him pronouns. Mental and behavioral health coordinator in SIB. And yeah, I can give a couple examples of things we testified in support of last year related to mental and behavioral health that might give you a sense of where we might be going this year. So just a few examples, we testified in support of the school mental health assessment bill, HB 231003, I think, which gave schools the opportunity to opt into a program to provide universal screening around mental and behavioral health for their students. We also testified in support of a bill that would allow licensed psychologists to prescribe mental health medications, really helping to expand access to mental health services. And we also testified in support of a bill that would remove the requirement for diagnosis for children on Medicaid to receive mental and behavioral health services. So a lot, I think, of what we do around policy, or at least what we did last year, and likely what we'll do again, is really focused on access to mental health services. How do we make them more accessible, more affordable for community members, and more equitable as well?
And then just one more to add is in 2021, our little fentanyl group that we have going, the district attorney, he actually worked at the legislature to push for a harm reduction expansion bill. So that helped to expand the funds for a lot of communities who just didn't have even a harm reduction program. So they were able to initiate and get started on with that funding. So I do think that we are leaders in that area, but mental behavioral health has been so underfunded for so long in Colorado. I do feel like it might take some time. And I think a lot of it
like readily available as a result of all of that, which is pretty amazing.
Yeah, and I worry a little bit on the continuum of need that the treatment side will get more money because it's right, it's needed right now. But we don't want to forget about the prevention. That's the importance of it.
It's super exciting to hear about the policy stuff that you guys are doing. When we go public with this, I think you guys should share more about what you've already done. Like, I think it'll really get people excited about where we can go from here. The last question, thank you for humoring me, is I think it was really intelligent of you all to use like existing data rather than burning out our community members for giving you feedback for this. But I'm wondering, what does it look like for continued feedback? Like if we, on a yearly basis, we're wanting stakeholder feedback, is there a process for that that also sort of takes into consideration the stress level of the people that we also are wanting feedback from?
Yeah, I'll jump in very quickly, but Rachel, I see you eager to jump in as well, so we can tag team this one. I think absolutely. I think the short answer is that absolutely, and exactly to your point, Amber, we want to be mindful of how we are collecting that data. So as we've alluded to previously, the behavioral health roadmap that our colleagues out of the community services division here in Boulder County are kind of their initiative that they're leading and that this is feeding into, and we are working towards that alignment. They've also expressed some interest in doing this kind of ongoing regular check-in with community and assessing, getting a pulse for where we are at. Are we still on the right course? Do we need to pivot? And so I think that's definitely something we are interested in and want to explore in partnership with them so that we can, to your point, not be duplicative in our processes, not be asking the same partners or the same communities same questions, slightly tweaked. So definitely something we are interested in. But Rachel, I apologize. I jumped in. Were you going to add something to that?
No, I was going to say, yes, we want to do that, but we don't have that outlined just yet as to what that process would look like. I was thinking in conjunction with our strategic plan, because we have 6 priorities, one of them being mental and behavioral health, kind of doing that at the same time, obviously, because mental behavioral health is our priority, but getting community engagement and community feedback on all of the priorities and what that process would look like. So not specific to mental and behavioral health, but including all of them as well, but process to be determined.
Yeah, finding a way to triangulate all these different efforts so that we can collect that feedback without, with being mindful of our team's capacity, our agency's capacity, and also the capacity of the community to provide that feedback for sure. As Rachel alluded to, we've got lots of different things to triangulate in that space, but definitely very interested in, pursuing that as we move forward with our FIP and, as Rachel said, our strategic plan.
Okay, thank you all.
Morgan, did you have anything?
I did, yeah, thanks. Yeah, thanks to all of it. I find myself that I am a little overwhelmed by how many plans, both are mandated by the state, and then we have, coordinating those plans. So there's the CHA and the FIP, which are mandated by the state. There's the strategic plan, which, we all do. Then there's the behavioral health roadmap. And so I applaud you all who are charged with trying to align all of those to make sure that we're not spreading ourselves all over the place, and that there's some focus, and again, that we look consistent across all of those as we try to approach mental and behavioral health. I think, what I've heard just in sort of our conversations with the commissioners lately around the budget is that it can be hard even, at that within the county to understand what the various roles are for each department too. And so the more that we can kind of succinctly hammer home what public health is focused on versus community services versus HHS within the county, and then coordinating that with the city of Boulder and, and the various other cities that are putting resources into mental and behavioral health, which I know all of the cities do at some level, but it is certainly the hot topic of the city of Boulder elections upcoming. And so just ensuring that whatever happens with resources going forward, that they understand what Boulder County Public Health is doing, and that we can all just, again, be aligned on that front. And I think it's great when, especially with mandated things like the FIP and the CHA, that information can actually be very helpful to us. So, I thought it was great. I mean, I think there's some really good concrete things in here, and concrete timelines, which I think is really helpful. And I think maybe not appropriate for the FIP, but as you all are working out what are all the steps that need to happen to get to the objectives that are outlined there, is thinking about, how do we know that we're successful? What does that look like? And then one of the things that I think the FIP does not ask for, or at least I didn't see it in there, and it's relevant to, I think, a question that Amber was asking too, is like, what's the accountability around FIPs? And I think this is a larger issue for the state, right? Requires FIPS, but there isn't any accountability for what that, what happened after the FIP. So I think that's just something that we, in Boulder County can maybe discuss. What's our accountability? What's it look like that we're successful, and how do we bring that back to the community with either regular updates or at the end of the FIP? So those are just some things. And then my last point is also around budget development. And I know that this department is working on a 3-year strategic budget plan too. And so ensuring that we see budget alignment with, the FIP and with the strategic plan, so that the resources that we have available to us, or the resources that we're trying to build, are really aligned with what we said we're going to focus on, which I know you all are going to do, but that's just want to make the point of it.
Yeah, and I'll just jump in. Thank you for that, Morgan. We really appreciate it. And just to speaking to your point around the kind of monitoring and evaluation piece, I think Rachel alluded to this in the presentation, but that is one of the big reasons why we are interested in integrating our FIP into our strategic plan, is that we have this measurement evaluation plan developed around what is the regular reporting internally and externally, and evaluating and making those data-driven decisions look like. So I think your point is well taken, that yes, we at the very least internally within our agency want to be able to make sure that we at the end of the day can say here's what we accomplished, and here are some of the impacts we believe that we had in the community, and here are some of the tangible ways in which we feel like we have improved mental and behavioral health for Boulder County. So I think that's really well stated by you, or a good concern for us to be very mindful of as we move forward to implementation. The one last thing that's been tickling my brain, I think it was something that Indira said as well, and you were talking about the funding piece, Morgan. I think Indira was the one who brought this up, that we know that a number of other LPHAs across the state are also choosing mental and behavioral health. And I'm very curious to see what the state does with that information, given some of the concerns and constraints that we've brought up here. We are not the only county to be grappling with that, and the challenges of very strict or limited funding, or just no funding existing to address some of these areas. So I'm really curious to see, once the state does receive our FIP, and I know they've already started to receive more and more FIPs, where number one priority across the state seems to be this very topic. So see if there's any traction we're able to get there around this issue. I feel like there was something else that you mentioned, Morgan, that I was going to speak to, but it's escaped my brain. So I will stop talking and see if there's any other final questions for folks regarding our CHA or our FIP.
Yeah, I want to add something really quick too. So I think that Elise brought up a good point. I think it's a double-edged sword, right, with that, because it may bring us more funding, or there may be fighting for money, right? So I think we have yet to be seen what that will look like. And something else, and much to the annoyance of my team probably, that I'll say is that this isn't, we're not looking this as, bringing the tablets down for the mount or something, right? These things can change, and they'll adapt as our circumstances adapt, and and so that's one of the great things I think that we built into this and the strategic plan, is that sort of ability to shift and change when it's necessary and when it makes sense, based both on resources and on current environment, that type of thing like that. So.
Thank you. Yeah, I think these are all really good points, and I appreciate the level of detail, and great, thank you. If everyone's okay with moving on, we can move on to item 7, the director's report.
So just a reminder, if you'll send any further questions or comments to the team by November 3rd, we will be back in November to look for an approval of them as we go forward. And just to be really clear, the FIP is the same as our mental and behavioral health strategic priority in the strategic plan. So they're the same.
And I appreciate the level of detail of the director's report too.
Yeah, and I just want to give a special shout out to Rachel and Elise, and I know Dave did a lot in the background, and Kelly's leadership. This was a monumental task to take on for folks who were, brand new to our agency and jumping in, and I think they've done a spectacular job, and I'm just really appreciate all the work that you all have done, and thank you so much.
Absolutely.
Yeah, I appreciate seeing what everyone's doing on the project side. This was great. It was really granular. So thank you.
All right, so director's report. I'm just going to highlight a couple of things. We have hired our Healthy Homes position, which we're very excited about partly because it allows us to address some things that have been niggling at us, including lead in households, including radon, including a number of other issues, mold and asbestos. That work is going to be targeted to lower income groups and aligned with Oscar's initiatives to promote weatherization and some of their climate change initiatives. Very happy to have that position filled. We are implementing the ARPA NBH grant. If you'll remember, we got $1.3 million from the county commissioners to support mental and behavioral health for 2 years, and that is really an anchor for kind of getting us off the block for this FIP in part. When we say there's not enough funding, it's because the need is huge. And in addition to the ARPA NBH funds, we are also continuing to work with the opioid abatement funding opportunities that are being developed. So that kind of forms the anchor for our initial planning in this work. Wanted to mention that our HEAL program, our Healthy Eating and Active Living programs, fruit and veg program, won an award for the Longmont Farmers Market. Yay. This is a program that purchases local produce and then delivers it to low-income families, particularly to families who aren't eligible for other food programs like SNAP and WIC. So for instance, a lot of undocumented families are given support. It can also supplement families that aren't getting enough, because you probably know that the benefits in those programs are pretty meager, sometimes as low as $8 a month to go and spend, which is, not sufficient to really respond to need. But congratulations to the team for that award. And just to kind of round it out, West Nile is out. We're done with the West Nile season for the year. And we're moving over to COVID, flu, and RSV, which are, a little uneven. They have been picking up a little steam, but are not particularly consistent yet. So we'll keep an eye on them as the weather changes.
Get your booster. Not easy to find.
It's been harder.
I'm thinking.
Awesome, thank you.
Thank you.
Any questions, Morgan?
I just have a quick one about the director's report and the childcare inspection fees, which was just briefly noted, I think, in the director's report. And I know that we are looking at fees for various programs because of, what it costs our staff to do the work. But, this one is sort of hard, and I know there's some hesitation. I read it in the notes about whether or not to increase fees, and just having helped with our childcare financials over the years, I know that it is just so hard to make the numbers work for any childcare facility. So it sounds like I don't think any decisions are imminent in that space, but I am particularly mindful of just the burden on childcare facilities, and I know you are too, Daphne. So, but I just wanted to note it or flag it as that it stood out to me in the director's report.
Thank you. Yeah, we are trying to keep costs down in that particular space because it's a community that it's so hard to make the numbers work anyway. It's one of the few areas where we have control over the fees. So we will probably do a review just to look as kind of, due diligence, maybe do some comparisons with some other counties about their fees, but I do not expect that to be a big revenue generator because it is a pretty vulnerable community.
Yeah, and also just thinking about, is there any other way to supplement that cost? And even, I don't know how, like, if we are charging the school districts when we do inspections of, but they certainly have deeper pockets than individual childcare facilities.
Yeah, so there are actually some proposals on the table to expand where inspections need to be done. But we're taking a close look at that because we're concerned that those areas don't represent particular risk, and we can't find any documentation of any risk over the past few years in those spaces. And it feels like another unfunded mandate that the state is asking us to take on. So just trying to be mindful about, what are our priorities? Where do we think we can do the best good for the community, given that FTEs are precious? What's the most important work that we can do in this space? Daphne, did you want to add anything?
No, just thank you. Appreciate you recognizing that challenge, but no, nothing to add.
Keep us posted, and thanks.
Indeed.
Just a little aside, I'm happy to help promote the Family Connects program more at Vista. If I could get some information on that, that'd be awesome.
It's so convenient that you mentioned that because we have Family Connects on the agenda for November. We would like to do, we launched about a year ago. Daphne has been anchoring that program, has put her heart and soul into this launch, and has made an enormous amount of progress. And we will be giving you all a presentation in November, and you can expect to find some background information in the director's report before the meeting.
Awesome.
And I'm also just super grateful for that offer. We're meeting with Avista actually tomorrow even. We kind of meet with them regularly. And then Indira, I'm just, again, so excited with Indira as deputy director. She has some great relationships with hospitals, and we talked today about leveraging those. So thank you. Really, really appreciate it.
Oh, I'm excited to hear more about it. I'm happy to help. And then the Children with Special Needs program, is that the same as Child Find or different? Is that similar?
It's different. Child Find was based out of school districts. I'm not sure where it's funded right this minute, but that is a service, as you know, where the families get assessed and stuff. Children with Special Needs is it's funded by HCP dollars at the state level and the MCH grant, Maternal Child Health Grant. And it's intended to recognize that the space of early childhood is a great time to help catch up with developmental delays, as you know. And so that's what that whole body of work and that whole team works on. So they do like the ASQ onlines, and they do case management, and their whole goal is, and we're actually getting a lot of referrals from Family Connects, even when families, sometimes it's not the infant, but sometimes there's a 2-year-old or a 3-year-old in the home that gets kind of screened, or the parents are concerned or whatever. And so then our teams will come in and help them get connected to ongoing resources. So it's very short-term connection and referral, and very quick ASQ, which is Ages and Stages Questionnaire for those who aren't familiar with that acronym.
Awesome. Well, thank you.
We may want to partner with Landry, Daphne, for your Family Connects. Having a healthcare provider as an advocate might be a couple in different.
Oh my gosh. Absolutely. And Amber, Landry and Amber, just so appreciate the spaces that we can partner with y'all on, because and just so you're aware, Landry, we are deeply trying to, and you'll hear more about this next month, so I don't want to take too much of your time, but we're deeply launching into Longmont and partnering with Salud. So it'd be fun to pick your brain on some of that stuff too.
That'd be great. Yeah, I'd love to hear who you're meeting with and see if I can help in any way.
Thank you.
I won't hijack this. Old and new business.
Just one thing that's new, the November Board of Health meeting will be rescheduled for November 16th, which is a Thursday, just due to staff availability. So I've already updated the calendar invite, but I'll send more reminders as we get closer to that.
Anything else?
And I'm sorry I'm not there to meet you, Amber, but welcome. Glad to have you aboard.
Thank you. We'll have more opportunities.
Great. I think we can adjourn.
Thank you very much.
Thank you.
Thank you to all the staff.
Yes, good. Thank you.